that, but I'll turn off my video so that
No, not necessary.
Sometimes the picture doesn't come out so well because of the.
That's not required. Your video will be on, plus the screen will be on.
Is it okay to start?
Yes, sir.
So good afternoon, friends. I can see some very eminent personalities in the Zoom room, and I was going to say that I was told by Dr. Radhakrishna that the majority of the participants would be postgraduate students, a lot of MS and some specialty postgraduates. So I thought the principles and the basics were more important. Acute pancreatitis remains a very difficult disease to treat. And what better way to start than to look at the natural history that if you took 100 cases of acute pancreatitis, 60 to 75 are likely to be mild and 25 to 40 are likely to be severe. About 10 out of 100, that is 4 to 26 people will die. And this is been pretty much the story from at least before I began my training. Yes. So I'm going to address some key issues in acute pancreatitis. The first is there a difficulty in diagnosis? There are two conditions, perforating peritonitis, strangulating obstruction, as well as ischemic bowel due to either non-occlusive strangulation or occlusive strangulation, which can mimic acute pancreatitis, and especially in patients who are not able to give a proper history, and you may not be able to diagnose. In these conditions, a CT scan is required in the very first day of presentation. An ultrasound scan must be done in all, but a CT scan is not necessary if the diagnosis is fairly clear and can be done even at the end of the first week. And in patients who have very mild pancreatitis, probably a CT scan need not be done at all. Often I think it is overused in practice. We must clear the desk as far as biliary pancreatitis is concerned. The diagnosis of biliary pancreatitis is based on history and setting. Usually women, but not necessarily so. Men do develop biliary pancreatitis. Ultrasound may or may not reveal gallstones. Abnormal liver function tests are a dead giveaway. Raised liver enzymes can suggest biliary pancreatitis with associated cholangitis. But remember, alcoholic liver disease, alcoholic hepatitis can also produce the same findings. So it's important to see the clinical setting, past history of abdominal pain or calculus, biliary disease or recurrent pancreatitis. And if there is a clear indication that this is biliary pancreatitis, and if the enzymes are raised, then ERCP and sphincterotomy is justified in the early phase. Otherwise, there is no need for early ERCP and done later. Am I audible?
Yes, sir, very much.
Okay. If I had to do a rough approach to the acute management of acute pancreatitis and use a mnemonic pancreas, not necessarily in this order, the most important things when a patient presents are A, analgesia, and C, fluid, crystalloid or colloid. Analgesia, it's preferable not to use NSAIDs. Tramadol is what is used for patients who are in the emergency or in the ward, and fentanyl when patients are intubated or in the intensive care. There's been lots of controversy as far as how much fluid you should give. The Mayo Clinic published a seminal paper in 2011, which suggested that aggressive fluid resuscitation in the first hour, golden hour after acute pancreatitis, would make all the difference between pancreatic ischemia and no ischemia and aborting of the attack of acute pancreatitis. Lots of data was accumulated, but by the year 2015, 4 years later, it became apparent that giving a hell of a lot of fluid actually flooded the lungs, increased the pulmonary issues, And therefore, it is now recommended that you do a goal-directed approach. When you say goal-directed approach, there are three components. The first is a mean arterial pressure, which is above 80 millimeters of mercury. Second, a urine output of 0.5 mils per kilogram per hour. And third, a lactate under 2.5. If these three are met, you don't have to give more fluid. Crystalloid to colloid ratio was recommended 4:1, but more and more intensivists want to give 2.5 to 1 crystalloid colloid. They believe that more crystalloids means more lung flooding. There's no hard data, there is no conclusive evidence, and we are still learning about it. It is as the patient appears, we need to be able to eyeball the patient and see whether we are dealing with a severe pancreatitis or a mild pancreatitis. If you have a MD calc in your mobile phone, and if you use the bedside stratification score, for acute pancreatitis, the BISAP score, you can easily decide whether the number of criteria are less than 3 or more, depending on which you know it's severe. You need to give oxygen supplementation if the oxygen saturation is low, sometimes non-invasive ventilation, sometimes intubation. Most patients with acute pancreatitis in the emergency will receive antibiotics, even though we must try hard not to prescribe on an empirical basis. In a patient who has respiratory difficulty, some amount of abdominal tenderness, guarding, and distension, uh, it is maybe important to put in a nasogastric suction, keep the patient nil per mouth. Of course, we must do an ERCP in biliary pancreatitis. Uh, as we proceed, we must try and make sure that we keep nutrition in the picture, because nutrition is the key to maintaining the patient. You can use CT scan also to guide the stratify the severity of the disease based on whether it is a normal pancreas, or whether there is enlargement of the pancreas, whether there is peripancreatic inflammation, fluid collection, which may be one or more, and or necrosis less than 30%, more than 50%, or even more than 50%. And based on this, you can have different levels of complications. 0 to 1 point will be no complications and no mortality. 3 points, maybe 8% complication and 3% mortality. And if you have a higher number of points, 4 to 6, you can have a 6% mortality, and more than 7 points, a 17% mortality. Based on this, you can stratify the severity of the disease. If you had to decide at this point that as to which patients with acute pancreatitis need intensive care, patients who require fluid resuscitation and are unable to maintain themselves, patients who are elderly, patients who are obese, patients who have pleural effusion, patients who have BISAP greater than 3, who are desaturating in spite of oxygen therapy, and who have hypertension, acidosis, and oliguria, must also all be maintained in the ICU, as also patients who had a CT scan sometime who have more than 30% necrosis. Uh, Enteral nutrition is the key to maintaining the patient. It decreases the pancreatic infection as well as the organ failure rates in patients with severe pancreatitis. If you have paralytic ileus in that period, you don't have to give it. You can wait a day. You don't have to just have a knee-jerk reflex, but a small amount of drip feeding of 20 mils per hour may be very important. In immunonutrition is probably not beneficial. It may be a good idea to give small amounts of feed, because you can preserve the mucosal gut barrier, and perhaps this can be further managed with IV nutrition with glutamine. There is no real role for prophylactic antibiotics or antifungals, although the Japanese Pancreatic Society and the Indian International Association of Pancreatology, in their guidelines, allow it for 14 days. I feel that many people get an antibiotic to start with The question is whether when should we stop. So if it's mild pancreatitis, we must stop it without any hesitation. Even if we have some invasive lines, such as a central line, such as a urinary catheter, you don't have to use that as an excuse to start antibiotics. You must do antibiotics only if you have clear-cut infection. Which antibiotic? And that's something that we have to address. Um, this is a list showing you the type of uh, antibiotics that are used in their terms of their penetration into the pancreas. You can see that the penetration factor is the highest as we go down. So whereas ciprofloxacin, imipenem, meropenem are all very high penetration, the question is whether, as Dr. Jaswant said, uh, 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 basically the necrotic material may not allow the antibiotic to penetrate, and therefore it's not going to penetrate into the necrosum. What is going to make the difference between survival or septicemia is the spread of infection outside. So you don't have to really go by this list to choose the antibiotic. Uh, there are some things that we already know in severe acute pancreatitis, that early surgery must be avoided because the initial problems are due to systemic inflammatory response syndrome. Necrosis, if present, has not demarcated, and early exploration increases the risk of subsequent infection. And therefore, the important thing is to do critical care. In fact, this is a seminal paper published in the Annals of Surgery in the year 1998. 22 years ago, Fernandez del Castillo plotted the survival of patients according to the dates of exploration. And over 50% of patients died when they were explored in the first week. And it's actually the mortality, the survival improved only from day 28 to a decent figure. So he concluded that when you really wait, that's when you can get better results. So the bottom line is to delay intervention as far as possible, and there have been many papers, including a randomized trial, which has suggested that we should not do early surgery. What is shown at the bottom is a paper published from New Delhi, in the All India Institute of Medical Sciences and Pramod Garg's group, published in 2011, where delayed approach had better results. There are three exceptions to delayed surgery. If you have abdominal compartment syndrome and you are really up against the wall, the patient is not improving, there is progressive oliguria, progressive hypotension, and progressive vascular circulatory collapse, you have to do something. And then if you have a large collection, you can drain it. If you don't have collection and the edema in the dysentery, edema in the retroperitoneum is responsible, then a laparostomy or some such may become required. Although there is no evidence thus far that it actually improves the outcomes, but for want of anything else, you have to do it. If you have a suspicion of proof of bowel gap perforation or gangrene, and occasionally, very rarely, bowel perforation or gangrene does occur in acute pancreatitis, maybe because of mesenteric thrombosis. And or if you have the patient who have a pseudoaneurysm on the CT, and if angiography fails, and in fact, I remember when I mentioned this to someone, a famous Dutch surgeon said, if it fails angiography, it will probably fail surgery as well. And that's something that's probably true. The big problem as we go on to week number 2 and 3 is you have SARS, which is probably giving way to sepsis. And just using counts or fever or organ dysfunction is not an adequate way of distinguishing between SARS and sepsis. Aspirating the necrosum was a very good idea early on, but the problem that we have is if it is sterile and the patient is deteriorating, do we look for other sources? Is there a pulmonary source for infection? Is there some other reason? Often the picture is not very clear, and therefore nowadays it is not popular to do aspiration from the necrosum. Plus, to find a non-enteric route to the necrosum may not always be easy. So if you go through the colon, obviously you will get organisms. So there are many biomarkers which have been used, tried with varying sensitivity rates, but please notice that none of them have a sensitivity or specificity of over 80%. So far, we talked about what was known for many, many years in acute pancreatitis. And now we are going to talk about things that have changed in our understanding of acute pancreatitis. Earlier, we had simply two groups of patients, one who had interstitial edematous pancreatitis, where there was acute inflammation without necrosis. And these patients simply improved and completely resolved. There was no sequelae at all. And the second, necrotizing pancreatitis, where there was necrosis or peripancreatic necrosis, and those patients had further sequelae. However, the new Atlanta, published in 1992, 2002, has shown that the interstitial edematous pancreatitis also can be followed by sequelae, such as the acute peripancreatic fluid collection. And after 4 weeks, it will turn out to become a pancreatic pseudocyst. So a pancreatic pseudocyst in modern parlance is a encapsulated collection of fluid with well-defined inflammatory wall, usually outside the pancreas, but can happen within the pancreas, with no necrosis, which means you need to do an MR to find out if there's necrosis or not. If there's a little bit of necrosis, very minimal, it's okay, but if it's more necrosis, it becomes uh, WON. So in a patient who has necrotizing pancreatitis, you can either get an acute necrotic collection, which after a month becomes worn. It's not as though patients wait for 28 days to suddenly get converted to ANC to WON. It's a process. Often encapsulation may occur in as short a period as 2 weeks. In some cases, especially patients who are poorly nourished, not at all, and there'll be maybe no encapsulation at all. So it's a very, very, very unclear classification, but that's what everyone wants to use. So this is a more colorful picture of interstitial pancreatitis with the acute peripancreatic collection, which turns out to become a pseudocyst, and the acute necrotic collection, which becomes a walled-off necrosis. That is the first thing that's changed in pancreatitis, acute pancreatitis. The second is the emergence of newer modalities. Acute pancreatitis is unique because whether it's an abscess in the face, or whether it's a breast abscess, or whether it's a anastomotic leak, intensivists, physicians, surgeons will all agree that source control is the key. If you have source control, then you are on to a good thing. You give the best possible chance for the host to combat the problem. Whereas in acute pancreatitis is the one condition where source control is never apparently achieved in one go. And yet one goes on treating the patient. And this is something that has always been very bewildering to me as to why it is so. This chart shows you the options available to somebody who wants to intervene in acute pancreatitis. You can either manage them non-operatively, or in Japan, I think they still do transarterial injections of protease inhibitors, although there is no evidence anywhere that it helps. Overall, 20 years ago, the gold standard was open necrosectomy, either by debridement, reoperation, planned reoperation, lesser cycle lavage, or open packing, or even a lumbotomy incision in the side, which could be used to approach lateral collections. And then, as an emerging treatment in the last 10 years, we have had percutaneous drainages and percutaneous with sinus tract endoscopy, further developing to a video-assisted retroperitoneal debridement, and endoscopic and laparoscopic approaches. And we were all regarding them as emerging treatments, but I think pretty much it's safe to say that minimally invasive approaches have become standard of care today. And open surgery has been relegated to salvage procedures. What are the paradigms that have affected our understanding of acute pancreatitis? This is a patient who had intrapancreatic air and collections suggestive of infected pancreatic necrosis. He was not intubated, he was not ventilated, he received only supportive care. And from September, by October, he still had the same problems, and by December, he was on his way to recovery, and he remained well thereafter. So, apart from these, there are other case series which have been published of just pure primary conservative treatment, resulting in mortality comparable to surgery in patients with infected pancreatic necrosis. And this is perhaps the first paradigm shift that all patients with infected pancreatic necrosis, as evidenced by, say, retroperitoneal air, need not be operated or intervened by any method, just as a knee-jerk reflex. If the clinical status is stable, they can be placed under watchful care. In the year 2011, uh, the Dutch published some humongous data of close to 400 patients with severe disease, organ failure in two-thirds, infection in two-thirds, where just by doing percutaneous catheter drainage, they were able to avoid surgery, or they were able to salvage patients in 55% of cases with a 17.5% mortality. And this is unbelievable figures. And they concluded that the considerable number of patients could be treated by PCD without the need for surgical necrosectomy. And this became the second paradigm shift, that the knee-jerk reflex, which said you go and operate a patient if you find anything suggestive of infection, was no longer true. And this is 2011. So it meant that several combinations of drainage procedures were done. If there were vascular erosions into these collections, then as you can see here, you had to do coiling of the appropriate vessel, either the splenic artery or the gastroduodenal artery, as the case may be. Uh, I just want to briefly interrupt to show you these two CT scans. This was published in the New England Journal of Medicine, I think in the year 1994, and it's perhaps the most important CT scan because in the plain scan, as you can see, the pancreas is pretty much seen with only a rim of edema. But once you give IV contrast, you can see the areas of necrosis. And in this patient, there's more than two-thirds necrosis, suggesting that the patient has a high propensity to infection and a high propensity to organ failure and death. So if you have a patient who has collected, the critical questions are, where is the collection? How big is the collection? Is the is the collection close to the pancreas or far away? Collections can be as far away as the mediastinum or the pelvis, and even collections, even as track to the neck sometimes. How close is it to the parietes? If it is right here, it's different. The access from the parietes is poor, but if it's close to the parietes, it can be accessed by parietes. Please do look for enhancement within the collection on contrast enhanced CT scan. If there's enhancement within the collection, it's a sure sign of arterial erosion and conversion to a pseudoaneurysm. This is a situation where you have to urgently call the intervention done. You must see the wall of the collection to see how thick it is, and try to correlate this with the duration of the disease, when the pain began and where are we now, the spatial position of the pain, and also try and take make an understanding of how much fluid versus how much necrosis. There's more fluid. So I'm just going to show you a few videos. Zoom doesn't show these videos very well. The first is percutaneous necrosectomy. The second is, I think, endoscopic necrosectomy and laparoscopic necrosectomy. I'll try to play them. and I won't. I'll pause it and try to explain as we go along. Place a guide wire within the catheter and take out the catheter. And then you can dilate the tract either by using Amplatz type of dilators, like the PCN set will have that, or you can have a balloon dilator. To dilate the parietes, and in this case you can see the waist of the balloon disappearing, and there is obviously tract has become more dilated. Then pass a Thomson resectoscope, which again is a part of the armory of the urologist. Don't tell them that you're using that because they're going to be cross with you because they will think that you're contaminating the scope. And then you have options of irrigation, you have options of gently teasing away the necrotic material. Uh, Never try to do everything in one go. Often if you increase the pressure of the irrigation liquid, that itself will help disengage the necrotic material. And when it's large bits come out, then you have to take out the scope. At the end of the procedure, you just place the vortex catheter drain back, and you can send the patient back to the ward and repeat it on a subsequent day if you require. Even large bits of pancreatic necrosis can be removed, except that I said we have to take out the scope each time and then only and pass it again. This can be accomplished with balloon dilated. You probably need at least a LMA or even intubation. So big pieces can also be removed, but one has to be gentle. So big pieces can be removed through this instrument. The laparoscopic necrosectomy is a contaminating operation. It actually, in this case, there's a large collection in the paracolic gutter, and uh, the trocar is actually being placed into the collection. So you'll find that a lot of necrotic material is coming out through the trocar itself. But in this case, again, the peritoneal cavity was, and as you can see, a lot of pus and necrotic material coming out through the port itself. A lot of necrotic material can be removed, but contamination is a real problem, and our own experience with that has been very poor. Endoscopic necrosectomy is now quite popular through the back wall of the stomach. Obviously, it can't be done for lateral areas of necrosis, but if for central retrogastric necrosis, there's an option to really create a gateway, and then through the gateway to do endoscopic necrosectomy using a combination of various techniques, one of which is being shown in this video. And it can obviously be repeated. There are general rules as far as these are concerned, that the endoscopic approaches are good for central lesions, especially for late walled-off pancreatic necrosis. The biggest strength of endoscopic necrosectomy is the lack of fistula formation. Normally speaking, if you stay within the cavity, you will not get fistula. Cutaneous necrosectomy is usually an extension of the per case number of times, just like endoscopy also you can repeat, but fistula is more. MIRP is a more formal type of a necrosectomy. Laparoscopy, as I said, has some problems. Sometimes you may require open surgery in fact, you require a combination of these because if you have a central necrosis and you have a lateral necrosis, then you probably need to use two methods deal with it, as that is true for the laparoscopic surgeon as well. This is the third paradigm shift. So you made the first paradigm shift of conservative management in selected cases. Second is the fact that 50% or more than half can be treated by percutaneous drainage alone. And the third is that there is a shift towards minimally access approaches. On the one side, we can say we can be conservative, but at the same time, we also must remember that too much conservatism can kill the patient. So sometimes you may have to do a dual modality drainage, be more aggressive. You do, of course, central drainage, percutaneous drainage, as well as a transgastric stent drainage. And if you can do all that, you can have better results with most patients having completion of treatment and good outcomes. Whereas if you have single more interventions, more open surgery sometimes, and more deaths, and the cost also was higher. There have been some recent papers. This is in 2017, and the next one. This is the Penguin trial and the Miser trial in 2019, which have suggested that endoscopic transluminal approach is better than minimally invasive surgery. But the data is not so clear cut in favor of endoscopic approach, because in the endoscopic approach, 41% had a percutaneous catheter in situ prior to intervention. So a lot of the stuff was already dealt with, whereas only in a quarter in the other group was this percutaneous catheter intervention done. Somehow the data has been shown to be insignificant on p-value, but I think it's significant. The second is when we did endoscopic drainage, endoscopic necrosectomy, it was always 97%. It was preceded by endoscopic drainage of the collection. If the drainage of the collection worked, the patient did not go on to endoscopic necrosectomy. That meant the patient was generally better off when doing the endoscopic necrosectomy, and that was an unfair advantage of endoscopic necrosectomy. So I think the jury is out. If it is central collection, and if both techniques are equally applicable, I think it will be okay to do an endoscopic approach if the expertise is there, because fistula can be avoided. Our interventional radiologist is a key member of this team because he is necessary to decide the percutaneous drainage as well as to do angiography and embolization. And if you look at this, we looked at this left-hand panel of all the characteristics of the collection, and based on which we need to have certain approaches, where to use angiography, where to use endoscopy or retroperitoneal approach. That we need to be later the better, and if it is more fluid, it's better to do PCD or endoscopic drainage. And if it's full necrosis, maybe you require even open necrosectomy. While we saw this huge meteoric rise of minimally invasive approaches, we must mention that even in the last 15 years, the necrosectomy, open necrosectomy results have also been very good. And even with very severe disease, the mortality rates are quite low, and huge sequestra of the pancreas, as you can see here, were removable by open surgery. And as when there was colonic involvement, again, open surgery was required. So if there was central necrosis, cephalic necrosis, multilocular necrosis, or if there were bowel complications, we may require to do still open surgery. So open necrosectomy is not obsolete. And we must remember, although it's history now, that three surgeons use three different methods to treat infected pancreatic necrosis with remarkably low results. Washout, Beggar, and Bradley from Boston uh, again, Atlanta, and from Germany. They had single-digit virtually mortality results with open necrosectomy. So again, I go back to my picture, and I want to re-emphasize that we must keep this in the top of our mind whenever we approach a patient with severe acute pancreatitis where some intervention is planned. The radiologist, the endoscopist, and the surgeon must all work together in this process. There is a fourth paradigm that instead of doing one big operation to take away all the problems of this pancreatic necrosis, why can't we do small drainages, either a percutaneous drainage followed by some necrosectomy? And if you wish, you can still do the open necrosectomy later, a step up approach. And the Panther trial, again published 10 years ago, uh, which also underlined the fact that 35% who underwent percutaneous drainage did not undergo necrosectomy. That is the first thing that you learned. And the highlight was that although the mortality was similar, there were more major complications with the step down approach and more functional debility and hernias in the later stage in the step down approach. But the ICU stay, hospital stay was not much difference. And 290 out of 380 cases were excluded. The biggest problem in doing a randomized trial in acute pancreatitis is to find two groups of data which are comparable, because the patients are so varied in their presentation, the spectrum is so wide, and therefore even the Panther trial has this weakness that out of 380 patients, only 90 patients were included in the study and 290 were excluded. And so we have to take all this with a liberal pinch of salt. The potential benefits of the step-up approach is that there is a second hit, in addition to the first hit of the pancreatitis, of a major abdominal surgery. You do the major necrosectomy, you say you've done a great job, but the patient goes on the ventilator, back to the surgical ICU. You do the percutaneous drainage or percutaneous necrosectomy, the patient may go to step down ICU and is not on the ventilator and is just receiving oxygen through nasal prongs or through the face mask. And there is a theory that many patients have fluid plus necrosis. And if the necrosis is and the fluid is infected, apparently there is necrosis was removed, it did not grow anything. The fluid, you grew everything. Therefore, if you drain the fluid, that's how you could avoid the operation. The third is when you do necrosectomy, however careful you are, you're probably removing more pancreas and there may be more functional loss. So that's the fourth paradigm shift. So we've talked about four paradigm shifts that we have seen today in the field of management of acute pancreatitis. Uh, One of the problems that we have with the minimally invasive approach is in open necrosectomy, we can use the educated sensitive finger, which we cannot use in any of these other methods. Earlier, bleeding was a big problem with open necrosectomy. Was it a problem with the open necrosectomy per se? How is it that it's not happening at all today? Are we dealing with a milder disease? We have limitations in gadgetry, both in endoscopy as well as minimally in laparoscopy methods. We are, I think the PGI Chandigarh is trying to present some methods of emulsifying the necrosis. And the biggest problem with the ongoing necrosis and the treatment is the bowel fistula, which may be presenting late to you and which may require an ileostomy. Among the last things that I want to mention here is that John Winzer's group talked about a failure to report our data properly. So they suggested that we must use 4 terminology in our reporting, depending on what are we trying to do? Are we trying to do a drainage, debridement, or lavage? What is the route we are using? Is it a percutaneous route or a per os, like transoral endoscopic visualization or hybrid visualization or open visualization? And what are we targeting? Are we targeting a pseudocyst? Are we targeting a WN? Are we targeting necrosis? So based on this, you can clearly say what is it that you're treating so that we can compare the data that I present with the data that you present. Ultimately, the evaluation of a procedure will depend on feasibility, applicability, safety, efficacy, and costs. Nearly all these procedures are feasible, but what is to be applied in a single case has to be based on this formula again. And it must be decided on the basis of a multidisciplinary approach, something that is not always present in all hospitals, in all environments, which must be taken care of in management of acute pancreatitis. I think the critical care physician is a very integral part of the management, and he or she must be the central focus or pivot around which all the other specialists will function. If I had to summarize the treatment of acute pancreatitis, if I had ruled out perforative peritonitis or ischemic state, then I do hemodynamic stabilization, stable oxygenation, give pain relief, and provide organ support by ventilation, by pressor drugs, by CRRT if required. Treat biliary pancreatitis if it is so. Continue in ICU care, manage and manage sequelae. Uh, and remember, and this is an important slide because remember that these three mountains have to be given due importance. That patients have SIRS and then they show the free area of necrosis, and somewhere along the line the infection also creeps in. So, in conclusion, despite a dramatic increase in minimally invasive approaches and a step-up approach, it is even more true to say today that a tailored approach is absolutely required based on the disease and patient characteristics, and that has to be combined with high intensity intensive care and multi-organ support, and that alone will give the best results. I'd like to end with this Robert Frost poem. The woods are lovely, dark and deep, and I have promises to keep, and many more miles to go before we sleep. And I think it's absolutely true of the management of acute pancreatitis that there are many more miles to go before we can, in a reproducible manner, be able to manage consecutive patients of acute pancreatic, severe acute pancreatitis with the promise that we can have low mortality and low complication rate. Thank you very much for your attention.
Thank you, sir, and brilliant lecture as ever. And it's a very comprehensive, complete lecture. And I threw open the field for questions. There are about 138 participants. If anyone who wants to ask a question, please unmute yourself and ask your question.
Hello.
Yeah, yes.
Yes, good evening, sir. Sir, is there any role of lipid profile in acute pancreatitis, like to rule out hypercholesterolemia?
Yes, I mean, I didn't talk about the evaluation of the cause. If you have a triglyceride level over 1,000, then there is a etiologic relationship to acute pancreatitis. In general, the hypertriglyceridemic pancreatitis is self-limiting, but in some cases it can become severe. And by and large, treatment is supportive. I just read a recent paper on plasmapheresis, but I think that's a very small number of patients, just 2 or 3 cases. Mostly, conservative management is sufficient, and then you can use fenofibrate or some medication for the hypertriglyceridemia.
Right. So, what is the role of nasojejunal tube in pancreatitis?
I think if I realize that the patient has severe pancreatitis, and let us say it's not mild pancreatitis, the next step is to place the nasojejunal tube. There are many ways of placing it. Our own method your choice is to use a radiologic method to place the tube in the stomach and to give metoclopramide and wait, and several hours later we find that the tube has found its way into the jejunum. Test feeds are given, and then you can give NJ feeds. I think that is one of the central treatment modalities as far as we have now.
Dr. Dinesh, what is your question?
So, good evening, sir. This is Dr.H.Ramesh from Madurai. Sir, my question is regarding post-traumatic pancreatitis with a ductal disruption with a small collection right at the neck. How can we go about it, sir? And patient is presenting on day 2 or day 3.
So, isolated pancreatic trauma is uncommon if it is due to blunt abdominal trauma.
Yes, sir.
If it is due to specific handlebar cycle injury, that's the commonest reason why you get pancreatic fracture at the neck with a collection. The first, if you see it on day 0, there have been some reports of even surgical drainage uh, and even repair of the duct, but generally that is not feasible. What is ideal is to allow a pseudocyst to develop and to drain the pseudocyst into the stomach endoscopically. There is one problem here that the distal uh, upstream pancreas is what is going to drain into the stomach. And the moment you remove the stent, place it endoscopically, the cyst will recur. So you have a choice between lifelong stent and trying to bridge the gap or do another form of drainage. So there is a role of ERCP and trying to bridge the gap between this the fracture. If you do a CT scan and the CT scan shows you that there may be only a partial rupture, then one attempt to pass a guide wire up into the upstream duct by an experienced endoscopist is worthwhile. But if the pancreas is completely fractured, an ERCP attempt can only increase infection. So we come back then to what to do with the upstream duct, because now we are dealing with a ductal disconnection. So many endoscopists manage patients by keeping the endoscopic stent forever. That is one option. The other that I would do is perhaps to drain the upstream pancreas into the jejunum or the stomach by surgery.
Dr. Swapnil?
So why do we give tramadol and not give NSAIDs, knowing that it is an inflammatory process that's going on in the pancreas? And what is the role of tramadol, because it hampers the sphincter of Odai's function?
First of all, tramadol doesn't hamper the sphincter of Odai, cause spasm of the sphincter of Odai function, just like unlike other opiates. That is what I have understood. If you have different information, please share it with me. The NSAIDs, and first of all, there's a randomized trial published in Modern History of Medical Sciences which showed that NSAIDs were inferior. Plus, in a critical care situation, use of NSAIDs has resulted in a lot of renal injury, acute kidney injuries. And as such, in our intensive care unit, as well as in the post-operative record, avoid NSAIDs is what is written. So I would strongly pitch for avoiding NSAIDs. I don't think we are dealing with a inflammation like like a contusion in the ankle where you use NSAIDs to decrease the inflammation and the pain. I think the analogy cannot be used.
Aditya?
Yeah, hi. Good evening, sir. I'm Dr. Aditya. I have a small question. What is the importance of serum amylase and lipase in the prognosis or to identify the improvement of the condition?
I think they have no role. Persistently high amylase could signify the presence of large fluid collection or continuing uh, ductal leak. But that's something that you can make out clinically. You don't need amylase for that. The lipase is usually persists for weeks to months, and it's of no use because the high lipase levels does not tell you the severity of the disease or how quickly it is responding to treatment. So I think both of them are really not beneficial in the way that you mentioned.
Thank you so much, sir.
Avik, what is your question?
Hello, sir. I want to ask the question regarding the traumatic pancreatitis, which previous fellow had discussed. Suppose the patient present with after a couple of the months, and at the time this is the real case scenario, so I am discussing with it. Suppose now after 2 months we plan to go in and try to do the distal pancreatectomy, but during the exploration there was a frozen abdomen, so we couldn't proceed further. So sir, what will be further plan of management if such thing happens?
Please
If
clarify now, 2 months after the injury,
after the injury,
what is the imaging show? Does it show dilated
disconnected.
no, no. Please listen to my question.
Yes, sir.
Does it show a dilated upstream duct?
No, sir. The distal part of the pancreas is disconnected from the body or mid body,
Is the
and
upstream duct dilated or not?
it could not be visualized or properly visualized. The distal duct
On the CT scan, it is not seen.
not seen
Not seen on the MRCP either.
in MRCP or CT either. And
Does
the patient didn't undergo any percutaneous treatment or endoscopic treatment.
So the patient does
due
not.
to
The patient does not have any fistula either.
Either no any fistula.
Yeah,
So
what is the patient's symptom?
So patient present with abdominal distension and pain after 1.5 month after the injury. So we did the ultrasound. It was shows that there is a multiple loculated collection. So we did the CT. Then it shows that the distal part of the pancreas, tail of the pancreas, is disconnected from the body or mid part of the body. So due to the course content, we didn't proceed for the ERCP or any percutaneous drainage. So we decided to let it go for the distal pancreatectomy. But at the time of exploration, we find the abdomen is completely frozen.
What is the current status of the collections?
But we didn't further process, so we put a drain into the abdomen, and the patient didn't count the follow-up now.
No. I mean, when you decided to explore the patient,
yes, sir.
Was a repeat CT scan done?
Repeat CT scan is done just a few days back only.
What did it show? Did it show the collections?
Yes, sir. It shows the collection, multiple intra-abdominal collection, which might require 2 or 3 percutaneous drainage if we plan for the percutaneous drainage.
So why are you not draining the collections?
Because we thought that it required the anyway going to convert into the pancreatic fistula, and the patient is residing at the remote area from our center. So, and the distal stump or distal pancreatic tissue which we can visualize is disconnected from the completely disconnected from the body.
How did the patient reach your hospital if he were in a remote area?
So he was referred by some surgeon for the further management. What can be done in that case?
In our country, with the excellent transport facilities that we have, I am not able to accept this issue of remote area unless you're talking about
yes, sir.
Nubra Valley, which gets closed off once there is snow on the Karbangla Pass. So there you can say it's remote, but if it is 300 kilometers from your home, from your hospital, it does not mean it's remote. I think the logical step would have been to drain the collections, or if the collections were accessible endoscopically, or to drain them endoscopically.
Then it is a multiple loculated collection. That's why I'm saying the collection cannot be drained by the single pictal or a single percutaneous treatment. So that's why we are planning, because it might require the multiple percutaneous drainage, or the collection is not drained by the single ERCP procedure only.
I would like to tell you that it is probably unwise to assume these things. It is possible that these collections are actually interconnected in some way. It is possible. Yes, it is possible that if you drain the largest collection, the others may subside. It is possible that now 2 months later, the patient is completely stable, has no sepsis, and ERCP may actually bridge the gap. And all these are possible. So I would not. I'm certainly disappointed that you wanted to resect the tail of the pancreas in a patient who is otherwise relatively, at least mildly symptomatic, not very seriously symptomatic. And even if I had wanted to do something for the upstream moiety, I would have liked to drain it rather than to resect it as far as possible. I want to preserve the pancreatic parenchyma, knowing that.
Yes, sir.
Are you from Gujarat?
Yes, sir.
So I can understand that from your
Let's
accent.
move to the next question, sir. Subnit Singh. What is your question, Subnit?
Sir, actually, grading the severity of acute pancreatitis. So, are we still following the Ranson's and the Glasgow scoring, or have we moved now to the Atlanta and the modified Marshall scoring for severity of pancreatitis, acute pancreatitis?
So in my talk, I had suggested to you that you should use the BISAP scoring, which is a bedside score. And on your phone, you can have a app called the MD Calc, which will allow you to calculate the BISAP. You can actually install it in your nurse's phone as well. So every patient who comes with acute pancreatitis will have a BISAP score recorded at any given time. And that can be recorded any number of times in a day, any number of times in the week. And probably that's the most reliable from the beginning, because you don't have to wait for organ failure to happen, but even before that you can. So I recommend that you follow the bedside score, which is the BISAP score.
Okay, sir. Thank you, sir.
Magna, what is your question?
Good evening, sir. So my question is the role of somatostatin analogs, aprotinin, and platelet activating factor inhibitors in acute pancreatitis.
Currently, no role for pentoxifylline, no role for any of these drugs, no role for ulinastatin. Although I confess that some of these drugs have not been properly evaluated, but platelet aggregating factor antagonists like lexapopant were very extensively studied. Initial data was promising. Then they had two large randomized trials on both sides of the Atlantic, and they found no difference. So British Biotech lost 2 billion pounds of money on lexapopant, and they went out of business. So it's been a difficult task to treat acute pancreatitis because the bomb has gone off within the asinus, and at that time we are not able to know what happened. Even in ERCP pancreatitis, we are not able to prevent it reliably. So afterwards, we are actually, it's like saying that the pipe is broken in the bathroom, and you're trying somehow to do a damage limitation. That's all we're able to do. We need to fix the pipe before it bursts. That's the problem.
Okay, thank you, sir.
So there's a request for your comments on how to manage pancreatic ascites.
Pancreatic ascites is a specific condition where, because of disruption of the pancreatic duct, there is collection of pancreas amylase-rich, protein-rich fluid in the peritoneal cavity. This is more an accompaniment of chronic pancreatitis. In acute pancreatitis, there can be amylase-rich fluid in the abdominal cavity, but it is overwhelmed by the initial SIRS and the initial protein manifestations. So there is, when we talk about pancreatic ascites, you are usually talking chronic pancreatitis, where there's a stricture maybe in the head, and there's a body disruption, and then there is leak into the pancreatic, into the peritoneal cavity or the pleural cavity. Their treatment is primarily, if at the first stage you can do endoscopic stenting and get over the pancreatic disruption. If there's a lot of ductal pathology, then you may need to do surgery at some point, but this is an excellent indication for endoscopic therapy.
Arun Nair, you want to ask a question? So Arun Nair's question is, how will you approach a large symptomatic horseshoe WOPN extending to both paracolic gutters with minimal retrogastric collection? It's a horseshoe collection, both paracolic gutters with minimal retrogastric. How will you deal with it?
So if it's very well encapsulated, and if the collection enteric interface is less than 1 centimeter, and EUS is able to show a clear passage to it, very comfortable passage, then I'm happy to have it treated endoscopically. But if there is some limitation in the access to the stomach, as maybe obviously the person who's asking the question wants to suggest that there is a generous paracolic compartment, then you can go the other way and do the paracolic drainage, and then you can decide whether there are actually two loculi or a single loculus, and depending on that, you can tackle the next one.
And there's another question. It says, sir, diversion ileostomy during necrosectomy, to do or not to do?
Just routine diversion necrosectomy is not required, I think, but in many cases, what one finds is, depending on the approach to the necrotic cavity that you have taken, this usually happens in open necrosectomy because you have to get to the necrotic cavity. You have to either go in the gastrocolic omentum, which may be very difficult. It's often possible to go to the left of the patient's left of the middle colic vessels. That is sometimes easier. But whatever you do, you find that the large bowel is inextricably stuck with this process, and when you try to even understand what the degree of involvement is, you kind of feel that it's part of that entire necrotic process. You would not want to discover 5 days later that the patient has fecal matter in the drain. It's also one of the big risk factors for mortality is colonic involvement and undiagnosed colonic involvement. And so it may be wise in that situation to do a prophylactic ileostomy. That's a selected group. By and large, otherwise, look out for a bowel fistula. If you see the first sign of a bowel fistula, do an ileostomy.
There's a question from Sunil Raviraj. He says, what is the role of pancreatic enzymes supplements in acute pancreatitis?
There is no role in the acute phase. In the the recovery phase, as Rajesh Gupta's paper from PGI showed, that a substantial number do have exocrine and endocrine deficiency. So patients who do not, thrive, patients who have difficulty digesting their meals, patients who have steatorrhea will all require pancreatic enzyme supplementation, but not as a routine, not certainly in the acute phase.
Yeah, Dr. Raghunayak wants to know your take on the use of streptokinase during lavage in organized necrosis.
I have no experience with the use, and I'm not quite sure that it is effective. It's not a standard of care at any rate, and if he has experience regarding this, he must share it with us.
There's a gentleman who wants to know the role of low molecular weight heparin as a prophylaxis against visceral venous thrombosis in acute pancreatitis.
Yes, there is data that suggests that there is a thrombotic tendency in patients with severe necrotizing pancreatitis, and low molecular weight heparin is perfectly part of the treatment. You don't have to give therapeutic anticoagulant levels, but just as you would do for patients who undergo major surgery or who are immobilized, you can give 0.2 milligrams of enoxaparin once a day is good enough. In some selected patients who have CT scan showing venous thrombosis, then you may have to give twice a day dosages and also manage the patients accordingly.
So what in your mind, the best painkiller in patients with acute pancreatitis is mildly deranged LFTs, best painkiller?
When I say mildly deranged LFTs, I don't know what you mean, but in our hands, we generally give, first of all, we would use tramadol. If it doesn't work, we give a fentanyl infusion. That's what we would use.
Siva wants to know the role of octreotide in pancreatic fistula.
The data suggests that octreotide will help in diminishing or completely, healing of pancreatic fistulae. But at least from experience, I don't see that happening, not for many weeks. So if it's a innocuous fistula, in the sense there is no sepsis, it is collecting directly outside, then there is no hurry to treat the patient. You can have 200 or 250 mils or 150 mils of clear pancreatic juice, which are draining into a colo bag, and the patient can be allowed to recover for weeks or months. And then a very leisurely approach to morphology of the pancreatic duct, and appropriate treatment can be done. But if you have a pancreatic fistula which is not draining adequately to the exterior, where there is sequestered sepsis in the abdomen, then some form of percutaneous drainage or even surgical drainage will be mandatory. And I don't see octreotide making a huge difference to the whole healing process in such a situation.
Aditya, you want to ask a question? Aditya?
No, sir, nothing. That's all. Thank you so
You
much.
asked the question is how to manage disconnected duct in acute pancreatitis necrosis. No.
No, that was not me, sir. That was the other guy. Then next after me.
Okay.
I'm done, sir. Thank you so
Yeah,
much.
this gentleman, he commented all decisions are clinical. Is there a role for FNAC?
All
Decisions are clinical. I mean, what he means by that, I don't know. Is there a role for FNAC in acute pancreatitis?
I guess there is a role for a very selected situation where we find that you are not sure whether you want to explore or not. The patient has marginally deteriorated from his or her previous condition, and there is probably some patch in the lung as well, which suggests that there is an extra abdominal focus, and you really don't know whether the intra-abdominal focus is really critical. In such a situation, this could be a tiebreaker. But the reason that it has not been used nowadays is because mostly the attempts are to do the drainage in a more minimally invasive manner. Therefore, the decision is more easy, because earlier a surgical decision meant a very big operation, and therefore the patient would simply go from being on the face mask to a ventilator with PEEP and everything and a high FiO2, and then go through a very long and protracted recovery. So that's why it's probably of less use. Plus, it's been very confusing in practical terms, because once you found that there was a positive gram staining, then the team had to commit themselves to intervention, even if the morphology of the collection was not suitable, even if the patient condition was actually marginally improved. So the question happened: why did we FNA? So, but I still think a fence sitter patient, where you want to make sure that the infection is in the abdomen before you explore, it may be worthwhile to do FNAC, provided you do it CT guided, not ultrasound guided. That itself has its own logistics, because the patient will be on the ventilator, and you got a patient, wheel the patient with the ventilator into the CT room, and a CT guided FNAC which is able to avoid the transverse colon. If this is possible, then you can do it on that fence sitter. Difficult, but possible.
Narayanan is an interesting question. What is your opinion regarding early epidural analgesia in patients with acute pancreatitis? And does epidural analgesia prevent progress to necrosis?
Yeah, the data is not conclusive, but epidural analgesia is certainly a very appropriate way of management. But patients who are acutely ill and who are already being nursed in very many different positions, including prone ventilation and other modalities for respiratory care, sometimes it's difficult to place an epidural catheter and to preserve it. Plus, one does not want to, at least in our hospital, we do not want to expose the epidural space to possible nosocomial infection and keep it in that environment for a longer period. But in the acute phase, epidural anesthesia is an option. We don't have an experience with it, but I guess it's certainly something you can do.
Dr. Ramesh, in your experience, how much does your ICU guys get a role? Do they ever push you to do something which you think is not appropriate? Because they're the ones who keep asking for source control and this and that, and say do something.
Yeah, this is a big problem. We have different specialists looking at things differently. We have our GI physicians who are not very much interested in intensive care, and but they would like to do a procedure or two, and they are quite happy to put in an early percutaneous drain, something that I generally decry. I say that we only need to drain those which are necessary, We don't need to put a PCD in all of the collections. There are patients who can recover without PCD as well. And the other side, we have intensivists who are saying the patient is not doing well. The patient is still on CRRT. The patient is still receiving, 2% drugs. So aren't you going to do something? So often you have to do a soul searching to find if there is an indication for an intervention. And if there is, they are happy for you to do it. But if there isn't, then you have a problem because you have to convince them that you cannot do anything at the moment. It usually happens in the beginning of the third week or the second week when no clear-cut necrosis is available and we are reluctant to explore. That's the time when the patient is sometimes deteriorating. There are critical situations there where the patient, the family, and the intensivist, the patient, not so much the patient is paralyzed and ventilated, but the family and the intensivist team up to say, do something. We don't care if the patient dies. And, they really sometimes put pressure on us to explore. In some cases, patients have been salvaged, to be honest. So sometimes I give the credit for those recoveries to the family rather than to the treating doctors.
Jaya, one last question.
Sir, what will be the indications of ERCP in acute pancreatitis that itself can re-aggravate the pancreatitis?
So I would do a ERCP, biliary sphincterotomy for patient with biliary pancreatitis. And then after that, there would be a long gap. I would then probably reserve ERCP for loculated collections which are related to the enteral tract. And that may start only from at least third week. I will need that there is clear evidence that it is well plastered to the back wall of the stomach or the duodenum, and US would be also advisable to confirm that. So in between, there is one small group of patients who have, let us say, either traumatic pancreatitis or who have a slightly milder pancreatitis where there is no overt sepsis, but there is a ductal disruption on the MR, CP, or the CT scan itself, where there is this always dilemma. The earlier you do an ERCP, the better chance you have of bridging the defect. But there is a risk of infection. The later you do the ERCP, the lesser the chance of bridging the defect and tackling it successfully endoscopically, but then it's much safer. So you have to play it on a case-by-case basis, but there is a role for ERCP in that setting. But clinical sepsis, clinically toxic ill patient, no ERCP, except if it is for a retrogastric collection, which is well encapsulated and in contact with the stomach.
Sir, thank you so much for spending very valuable time with us and enlightening us and some very interesting question answer session. We'd love to see you again at 4 o'clock tomorrow with the lecture on chronic pancreatitis. Thank you so much, and I shall end the session.